Hi, everybody, and welcome to our third lecture. Our third lecture, we're going to step away from what we've been talking about, developing new clinical services, collaborative practice agreement, and we're going to talk about something that we probably talk about sometimes in our pharmacies, but maybe because it's kind of like on the low end of the Medicare star ratings, it's not as much weighted in the the pay for performance contracts, but it's very important because we deal with a lot of geriatric patients, unless you're a complete pediatric community pharmacy. And what I want to talk to you today is why are we so concerned about high risk medication in the community elderly? And what is this thing called Beers criteria? It's not something that, you know, tells me what's the best lager or what's the best microbrew out there, but it's telling you that my patient who used to be on this drug for years, it's no longer covered under Medicare D, and it tells me all these bad things may happen. And why does this occur? So once again, there's my financial disclosure that I have no conflict of interest. All I have in this is that geriatrics has been a passion of mine for the last 20 years. 20 years ago, I had the opportunity to do a geriatric residency down at the Duke Center of Aging and the Durham VA. And probably that time I spent doing that residency had a big impact on everything that I do in my career. And during that time period, not only did I get to learn, but during that time period, it was my first time I got to work in an ambulatory clinic, working directly with physicians. And what we did every day was look at high risk medications and whether or not we needed to remove them and how and what can we do best for that patient. And so what we hope to do in these learning objectives is kind of just give a quick review about, I'm sure you've read or attended lectures about why elderly people are more at risk for certain drug problems. Well, we're going to talk about what does this bright Beers criteria, because the Beers criteria got updated another time in 2015. And one of the things in 2015 it did was it also provided some alternative recommendations of what medications to try. So we're really going to deep dig into this. So I'll highlight each one of these learning objectives like I've done in the prior talks, but let's take a look at the first one. So one thing that I remember the very first day of my geriatric residency, and like I said, I was thinking about this the other day because I got to sit in on some new residents that were interviewing for some of the residencies at Duquesne, that it was 20 years ago this month that I actually was interviewing for residencies. And I remember the very first day in July of 1997 when I started my residency. And I remember the head of the geriatric department, physician, coming in, and he gave us this talk. And he said, you know what, there's two concepts in geriatric medicine. One concept is that whatever we do, the ultimate goal is to improve the quality of life of our geriatric patient. The second rule is before you make a change, is that change going to at least maintain their quality of life? And that's what we're going to talk about when we talk about these high risk drugs. Because some of these drugs can have, even though they were fine when we were young, they can have implications that may decrease a patient's quality of life or not allow them to maintain their quality of life. As we get older, our body changes. Changes occur gradually, it may happen slowly, it may go unnoticed for years. There's one theory that when we start reaching our mid 30s, that we start losing 1% of our organ function. Now that sound a little sad and glass half empty. However, does that mean that our organs don't function when we're in our 60s, 70s, or 80s? No, they just may not function as well. And so then if they don't function as well, what happens is they don't have as much functional reserve. And so when they are exposed to a stressor, like an adverse drug reaction, they may suffer more reaction or not recover as quick as they would when they were younger. You like to use, it's a terrible analogy, but if you compare a brand new car to an old car, and if anybody can think about the clunker that you had, when you were in college, I remember I inherited my dad's '81 Buick Skylark, baby blue, powder blue, and it had the AM radio, and it was built like a tank. But I remember many cold mornings in Pittsburgh where that thing would barely start. And I remember you let it run for at least about 20, 25 minutes, half your gas was gone, but it ran like a champ. And think about this. That's what happens. You got, as we get older, it's not that our organs aren't functioning. It's just they may not be doing it at the highest caliber. There's many different factors too as we get older that affects the way the drug comes into our body and leaves our body. And so some drugs we become more sensitive to, some drugs we become least sensitive to. Some drugs that, depending upon the way that they distribute throughout our body, the way they leave our body, may be affected due to these various changes in organ function, in receptor function. This is a summary of a lot of these physiological changes that occur. For example, absorption is usually not terrible, but what we see in absorption is that our pH in our stomach increases, and so we may not absorb acidic drugs as well as we did. So if I got somebody who's on a PPI and elderly and they have osteoporosis, they may be better well served using calcium citrate versus calcium carbonate. Some drugs, are do get absorbed okay, but there's a slow time for them to be absorbed. The other thing is some drugs that go through first pass metabolism is decreased. So, for example, morphine, which is a classic drug that goes through first pass metabolism, that's decreased, and that's why elderly patients may be more sensitive to morphine, and we have to start at lower doses than we would if we were younger. We can see some, changes in our skin, thinness. We may not have as much fat, so transdermal patches may not work as well. Body composition, it's the curse of getting older. We have a decrease in total body water, an increase in body fat, and a decrease in lean body mass, which also shows a decrease in lean muscle mass. We also see an increase in alpha-1 acid glycoprotein, and that alpha-1 acid glycoprotein can have an impact allowing drugs that normally don't cross the blood-brain barrier as readily do. And that's why you see certain drugs, and we're going to talk about anticholinergic drugs here in a little bit, that this can cause cognitive issues and problems such as that. We also see changes in metabolism and various different changes. Drugs that go through phase 1 metabolism can occur. Also, too, in terms of distribution, the more fat the drug is, the more it's going to hang around. The more water soluble is, the more potential that at smaller doses it become toxic. And then the other big one is we see our kidney function decrease, and then lots of drugs are cleared by the kidneys, and if we don't dose adjust them appropriately, can cause problems. So the big core of this talk is let's review of the literature of these high-risk medications. And then at the very end, we're going to talk about how can we may incorporate some of this knowledge into improving Medicare star ratings at our pharmacy level and recognize some clinical tools, and we'll talk about some case studies. One of the things I was talking in the prior lectures about, the different pharmacy services, improving pharmacy value, that I think that a lot of times we know, and we get frustrated by this, is that the payers are always looking at the product and the cost of distribution, and they always want to slash and cut that. But the problem is total drug cost really also includes utilizing the right drug for the right disease state and preventing ADRs. The purpose of trying to develop tools to identify high-risk medications is that there is data out there that shows that 25% of hospitalizations, and there was just another JAMA study several months ago that reconfirmed this, that anywhere from 25 to 28% of hospitalizations of elderly patients is due to ADRs of drug therapy. However, before we get into talking about the Beers criteria, I just want to bring out a point. And the reason why I want to bring out this point is there's two big players in this appropriateness of therapy. The classic one is the Beers group, all right? And then another one is a group of Irishmen all right, medical professionals that look at what's called the stop-start criteria. The stop-start criteria is very similar to the Beers criteria. However, the only difference of this is that in the stop-start criteria, they actually make suggestions of drugs we should use that we don't use enough of in elderly patients. And a lot of times, because everybody's worried about using drugs in elderly patients, is sometimes we see underutilization. So, for example, we may not treat somebody's depression. We may not put them on appropriate drugs post MI, like a high dose statin or, a beta blocker. We don't identify that they need vaccinations, a place that we can play a big role as pharmacists. And so, a lot of times these can be omitted. Start criteria. Like I said, there's the Beers criteria, but there's what's called the stop-start criteria. And obviously, stop is what medications we shouldn't use. But the start criteria are screening tools to alert doctors of what is the right treatment. In AFib, we should anticoagulate. And a lot of times, warfarin is the better choice in an elderly patient. And I'll talk about why, is because when we get into direct thrombin inhibitors, a lot of those are renally cleared, and for some elderly patients can be very contraindicated and at higher risk. And the biggest problem we have with the direct thrombin inhibitors is there's no reversal agent. Looking at the treatment of isolated systolic hypertension greater than 160, and drugs that have been shown to help treat that better are like thiazide diuretics, calcium channel blockers. Making sure that even though statin therapy for coronary artery disease and also for patients who are probably going to live beyond 5 years, ACE inhibitors for CHF and MI, beta blockers for chronic angina, obviously Cinemet for Parkinson's disease. And so a lot of these are pretty self-explanatory, but sometimes they get missed. Making sure somebody who's elderly, postmenopausal woman, that they are getting some type of calcium supplementation, getting a DEXA scan, whether or not they need a bisphosphonate for chronic therapy. And so those are just teaching tools. But the big crust, what we want to talk today about, is inappropriate utilization, the use of medications whose potential risks outweigh the potential benefit, hence may prevent somebody maintaining their quality of life or not improving their quality of life in a geriatric patient. And there's numerous methods out there, all right? And a lot of what the Beers criteria does has been adopted by HEDIS, which I told you earlier in the prior talks is the way we measure prescribing and physician practices. CMS uses it, an adoption of the Beers criteria to regulate nursing homes. I talked about the stop-start criteria, and explicit criteria is the biggest criteria we use. I'll talk about implicit criteria at the very end here of this talk, but explicit criteria is we use. And why do we use explicit criteria? Because we can computerize it. We can make great, nice little reports and graphs and charts. The disadvantage of it is usually it's an opinion. It's usually a consensus. And sometimes it doesn't apply to all patients, and sometimes the evidence is always not 100%. However, the Beers criteria evidence base is a lot better than it was prior to 2012. Implicit criteria is using and looking at that individual patient, evaluating their medical record, evaluating the literature. The problem with implicit criteria is just very time consuming. So in 2015, the American Geriatric Society updated the Beers criteria. And where did the Beers criteria come from? Well, it came from Dr. Mark Beers. Dr. Mark Beers unfortunately passed away in 2009 due to diabetes complications. But Dr. Beers in his lifetime was a geriatrician, and he was looking for a way to possibly teach his geriatric physician fellows on understanding about what drugs may not be appropriate. And so he published an opinion paper in the early 90s, and it just caught on like wildfire. And when after that one, he republished another paper in 1997, and in that one, he did a consensus where he surveyed pharmacists, physicians, nurses, what they thought were drugs that were problematic in elderly patients. And if you looked at that original list, there were a lot of drugs that, had been around for 50 some years. And a lot of them have very similar properties, and I'll discuss those. But after Dr. Beers died, the American Geriatric Society, which is a medical society for those who practice geriatrics and not just a for physicians, pharmacists, nurses can belong to this organization. It's a very good organization on geriatrics. Is that they decided to make an expert opinion team, and this team consists of physicians, pharmacists, and nurses. But they did a little bit different. Is they did still come up with a consensus, but after they came up with a consensus, they went out and looked at what is in the literature. What does it say? Is there evidence that yes, these drugs are problematic? This last time in 2015, they also put out some decree statements because they do know that because they're explicit criteria, that health plans and health evaluation organizations love to just use this criteria, and that's not what it was intended for. It was intended to identify possible medications that we shouldn't use in older patients, help reduce adverse events and drug-related problems, and design as an education teaching tool, research tool. All right? And it's supposed to look at what medications could have limited effectiveness in older patients due to changes in aging or just that they've been around so long, they're just poor evidence. And they are associated with poor outcomes. They could cause delirium, GI bleeds, falls, and there's already safer alternatives out there that we could use. However, implementation of the Beers criteria has led to several unintended consequences. Many clinicians misunderstand the purpose of the criteria, mistakenly believe that it's a criteria to judge all the uses of the listed drugs. And so some physicians get really ticked off when somebody says, well, you're on a Beers criteria drug. And I'll give you my own personal opinion. I'm not a big fan of some of the software that is out there helping you identify high-risk medications. And my reason is because they all like to put in a sentence that you're going to send to the physician. Dear physician, do you know your patient is on a Beers criteria drug, a high-risk drug? I hope that everybody who's listening to this, and I tell my students this every year that I teach them geriatrics, is please, when you're making a recommendation about a high-risk drug, do everything to make that recommendation by identifying the problem of this drug with that particular patient, not listing that it's a Beers criteria drug. That's like taking nails on a chalkboard to some physicians. The other challenge with these Beers criteria is that health systems have often reinforced this perception, implementing quality improvement and decision support systems that implicitly consider any use of this. And some prior authorization programs, we've seen this in our Med D plans, that just stop covering the drug because it's a Beers criteria drug. And sometimes the patient could benefit from the drug. Another key change to the 2015 publications was there was a publication on alternative medications for medications use of high-risk things. So if we're going to recommend to get rid of certain drugs, what are alternatives? And I will mention several of these throughout the talk. The application of key principles for clinicians. Don't let the Beers criteria distract you from closely attending to other elements of prescribing that are not addressed by this criteria. Those include high-risk medications that are not on the list, like warfarin, hypoglycemics that are not on the list, some of your direct thrombin inhibitors. It doesn't really address medication adherence, underuse of medications, and many, many more. You can go and get a lot of the resources about the Beers criteria at geriatricscareonline.org. A lot of these resources are free, so please feel free to check these out afterwards. When you look at drugs to avoid in older adults, I'm not going to go into every single drug. You can read that online, but there's some commonalities. A lot of these drugs are older drugs that are very lipophilic. They may have long half-lives in elderly patients. There's questionable of their evidence, such as musculoskeletal relaxants like cyclobenzaprine. There's also that a lot of these are anticholinergic. And remember learning the classic symptoms of anticholinergic: causes dryness in the mouth, blurred vision, decreased GI transit time, therefore risk for constipation, also urinary retention. But another one it can do is these drugs, because a lot of them are lipophilic, crosses the blood-brain barrier, and when it crosses the blood-brain barrier and starts interfering with cholinergic transmission, what occurs? Delirium, cognitive impairment. So the big issue that gets addressed in this is what drugs do this, all right? Because they may reduce acetylcholine, lead to dementia, cause other problems such as constipation, urinary retention, orthostasis, tachycardia, just dry mouth. And if you looked at you know Goodman and Gilman pharmacology book, you'd find there's over 600 drugs with anticholinergic activity. So does that mean every one of these drugs is bad? Not necessarily. However, there's been several different studies and links that have shown that these medications may increase the risk for dementia. But what we found in theory is what's called the anticholinergic cognitive burden. That maybe it's not one drug that causes the problem, but if you add two or three drugs, then that is where the problem lies. So, you know, one of the things that we try to do with the drugs that are on this list is what are other alternatives? And so some basic things. Can we avoid first generation antihistamines like diphenhydramine, doxolamine? All right, for those. And look at other alternatives. Other things that the Beers criteria list is an antibiotic, nitrofurantoin. Nitrofurantoin is great for urinary tract infections, but the reason why it's on the list and cautionary in geriatric patients is that it needs a good creatinine clearance renal function for it to concentrate. And if it doesn't get it concentrate, it's not going to kill the infection. The other thing is, it's really recommended not to use it as daily prophylaxis also, because if it accumulates, it can cause possibly pulmonary toxicities. And another one that's not always mentioned, it can also cause peripheral neuritis. The alpha blockers, and when we talk about alpha blockers, we're talking about your classic peripheral alpha blockers like doxycycline, prazosin, and terazosin. Now that tamilosin's been out for well over a decade, is tamilosin has less risk for orthostasis and is a better treatment option, especially in elderly men with BPH. Digoxin is another one. We try not to use high doses, and some of the reasons why is there doesn't seem to be no additional benefit of going above 0.125 milligrams in most patients. And what we're trying to do is getting that positive inotropic effect to give that extra squeeze to make the person feel better in congestive heart failure. We don't recommend DIG to be used in AFib and AFlutter anymore, and there's numerous reasons, and I'll go into a little bit more detail for that. As I said, there's now this year published alternatives for high-risk drugs, and so let's look at some high-risk anticholinergic medications. So, for example, disopramide, which is an old agent for AFib. It has a very negative inotropic effect. That's how it worked in AFib, by suppressing the AV node and preventing, sending signals back up into the atrium. So another recommendation is diltiazem. First generation antihistamines, we pretty much have all the second generation antihistamines over the counter now: loratadine, fexofenadine, and cetirizine. Other options is nasal steroids might be a better option for that patient, or in combination with a second generation antihistamine, a leukotriene inhibitor. And if you're going to use one, I would suggest montelukast. Zafirlukast, which was Accolade, has lots of drug interactions, specifically with warfarin and theophylline. Depression, tricyclics really shouldn't be recommended anymore. Tricyclics like amitriptyline can be used in neuropathic pain. And paroxetine makes this list too because it's very anticholinergic. That's why paroxetine's a lot more sedating as an SSRI compared. But think about it. In the years for neuropathic pain, we've developed gabapentin, lidocaine patch or creams are good for neuropathic pain. Duloxetine, SNRI, is one of the first drugs of choice for neuropathic pain. And so we can avoid classic. And the other thing we have to be careful with tricycline antidepressants, besides the anticholinergic effects, is that they've been known to cause heart block and orthostasis. Parkinson's disease, benzotropine and trihexyphenidyl were always first-line agents. They were also agents to treat EPS symptoms. They can still be used to treat acute EPS symptoms, but there's really no benefit for them in the long haul for Parkinson's, and it's never been shown to help delay Parkinson's disease, and they're just more problematic. Acute back spasms, a lot of times it's the old classic muscle-skeletal relaxant like cyclobenzaprine or orphanedrine. Both are very highly anticholinergic and sedating. In fact, there was a meta-analysis done years ago where they looked at that most patients reported only relief from cyclobenzaprine within the first 48 hours. And what they concluded, the researchers, were probably that patient just slept the first 48 hours. But there's not a lot of strong evidence that it's actually that efficacious. And so if we had to use other agents for back spasms using around-the-clock Tylenol, such as anywhere from 650 to 975 milligrams Q8. Salsalate, non-acetylated salicylate sometimes is not a bad option, and maybe also generic Celebrex. Another option, if you had to use something for spasticity, is anything that has clinical evidence. You'd be better off using something like tazazidine or baclofen. So, as I said, there's second generation antihistamines, nasal steroids, leukotrienes that can be used for allergic rhinitis. The other thing is I talked about DIG, all right, is that there's better alternatives for treatment of AFib. In fact, it's not recommended as first-line therapy anymore. Mainly beta blockers are. And, going higher doses increase the risk for hospitalization and toxicities. We shoot for a DIG goal of 0.5 to 0.9. And another reason why is as we get older, our renal function decreases, and DIG clearance also decreases because it's highly dependent upon that. So there's recommendations that we should only use DIG if somebody has a really poor ejection fraction, that we've maximized other therapies that have evidence-based as listed above. And we really only recommend, to control the ventricular rate when all resources have been tried. And the main reason why, too, is besides it can cause heart block, it could cause, obviously low heart rate, making a person feel sluggish, but it can cause confusion, anorexia, and weight loss. So, we talked about TCAs trying to avoid, but another big area is the use of antipsychotics and hypnotics and benzodiazepines. And the main reason why is there's a strong association of them for an increased risk for falls and causing cognitive impairment. Antipsychotics, rationale is we try to avoid them in older adults with or at high risk for delirium, because sometimes they've been shown that they actually may worsen delirium. In dementia, there's been evidence they may increase the risk for stroke and greater risk for cognitive decline. So the recommendation, the Beers criteria, is to avoid for behavioral problems with dementia. In fact, the evidence shows that when you use these drugs for behavioral problems, that there's only about a 30% response rate. And you really only use them in two different scenarios. If the patient's truly having a psychosis that needs to be treated. For example, I had an elderly patient in a nursing home we took care of at one time, and this patient had a psychosis that they felt they had to go pick up their daughter at the school bus every day at 3 o'clock. And her daughter actually was the medical director of the nursing home, and her daughter was in her 40s. Well, this patient would try to escape every day at 3 o'clock due to the psychosis. And so it answered this question: is the behavior either a harm to themselves or a harm to somebody else? So they're biting, kicking, scratching. And for those of you who've practiced in the nursing home setting, that is why behavioral monitoring sheets are necessary under CMS regulations for monitoring. And the Beers criteria is just reinforcing that antipsychotics are good for true psychiatric conditions, but we should be careful in using them for acute delirium and dementia. The other thing is, when we're treating agitation, maybe using things such as, SSRIs, but we also have to be careful there too. Drugs like citalopram is good for agitation. However, we have to be careful that, when we go above 40 milligrams, it can prolong the QT interval. So when we think about treatment of dementia, delirium, behavior symptoms, trying cognitive interventions. And so I've seen patients where you just get them to focus on a task or to sing, or light therapy, interpersonal approaches. And if you don't feel comfortable with these, refer them to, different, therapists who have good expertise in these areas. Sedatives and hypnotics, and this is why, remember when, Medicare D first came out, benzos weren't going to be covered at all. And there is a place for benzos at times, but we have to be careful. And what benzos should we use in the elderly? And, the big case is none, but if necessary, we want to use the ones that have a shorter half life and are also more hydrophilic. And so those that fall into that category is lorazepam or oxazepam, and they are safer alternatives to use for anxiety or sleep. Other options to help patients with sleep is, looking at their sleep protocol. A lot of patients, when they retire, they develop bad sleep patterns. They may be drinking caffeine after 5 o'clock. They're, they're got blue light. They leave the TV on. They may not be physically active. They're taking naps during the day. So there's lots of different ways of good sleep hygiene that may help improve sleep. Some other agents that meet the Beers criteria are magesterol, which can be used sometimes for weight gain. But the problem with magesterol, it's been shown to possibly, it can increase the risk for thrombosis and DVTs, and it's not that effective in weight gain unless the person's cachectic due to either cancer or HIV. The other thing is we'd like to avoid older sulfonylureas. I haven't seen chlorpropamide in years, but glyburide is a classic one, and that's why glyburide's not covered under most insurances. Glyburide has an active renal metabolite that still needs to be cleared and has one of the highest risks for hypoglycemia. Sliding scales are not recommended in chronic therapy, especially for geriatric patients, unless they're acutely sick, and that's because the benefits outweigh the risk. And a lot of times, depending upon the frailty of the patient, sometimes, and we'll talk about this in our diabetes talk lecture next, is that sometimes you don't need it to have as tight of a regimen. Metoclopramide, which is really unfortunately the only drug we have on the market now to help with GI transit for people who have things such as gastroparesis. But the downside of the drug is it stimulates acetylcholine, which helps move the gut, but is very lipophilic. And remember, it used to be an old anti-nausea drug. And how is it an anti-nausea drug? It blocks dopamine. And because it's very lipophilic, when you have a drug that stimulates acetylcholine and blocks dopamine, it's going to be more potential for developing Parkinson-like symptoms. In fact, elderly patients have a greater than 30% increase compared to non-elderly patients. Avoiding NSAIDs that have high GI bleed risks, such as older ones like indomethacin, ketorolac. And if we do have to use NSAIDs, use newer ones like, Celebrex or Mobic, meloxicam, all right, ibuprofen. And if you have to use these chronically to decrease the risk for GI bleed, put them on with a proton pump inhibitor along with it or misoprostol. Most elderly patients can't tolerate misoprostol due to it can cause a lot of GI effects and diarrhea for that. We also talked about skeletal muscle relaxants, earlier, and the main reason is sedation and falls. There have been some other new additions to the 215 Beers criteria. Avoid the use of desmopressin and PPIs no longer than treatment for 8 weeks. Added meclizine to the anticholinergic list. Added the Z drugs, not the Dougs, sorry about that, such as Lunesta, Zolpidem, only use them when possible, and also tried to avoid any type of hypnotics in combination with opioids. And the other nice thing about the Beers criteria is it addresses two other areas. It addresses drug disease interactions now, and it also addresses drugs that we need to either avoid or be careful with in renally clear drugs. Other new additions to the 2015 Beers criteria is trying to minimize and avoid opioids where possible, especially if there's a history of falls and fractures. And we'll mention this a little bit when we do our pain talk. Obviously, I talked about using PPIs. This is where you're trying to do a balance. We try to avoid PPIs as much as possible, but we may use them sometimes in combination if somebody has to be on an NSAID to decrease risk for GI bleeds. But we don't like to use them long term because they've been associated causing B12 deficiency, decreased calcium absorption, and therefore may put the person at risk for fractures. If they're an institutionalized patient, they may put them in an increased risk for C. diff infections. And so we kind of still have to weigh this balance. Like I said, The other thing that's encouraged throughout the Beers criteria is that companion article, drug therapy alternatives. The biggest reason why opioids got added to the list is that when you look at drugs that can have psychoaffective effects on elderly patients and put them at increased risk for falls and fractures, opioids falls right in there with anticonvulsants, antidepressants, antipsychotics, benzos, and sedatives and hypnotics. And there's almost a twofold risk of the risk for falls with these drugs. In fact, some recent studies have shown when you combine that the patient's on two of these drugs, it increases the risk even greater than fourfold. So, what do we do for chronic pain? Well, we need to think about this, and I'll bring this back up again when we do the pain talk. Is that, for back pain, what evidence is out there? Well, unfortunately, there's not a lot of evidence for the use of topical NSAIDs, capsaicin, or lidocaine patches. However, you may want to try those first. You may want to try traditional things such as acetaminophen, evaluate whether or not physical therapy may be a better option, whether or not local injections may be better option. Um, you know, Post-herpetic neuralgia for people having nerve pain related to shingles, where the evidence that shows lidocaine patches and capsaicin, some possible case reports of benefit with topical NSAIDs like ketorolac. Osteoarthritis, a good place to start is topical NSAIDs or capsaicin or lidocaine cream. Maybe not the patch because the patch is hard to get approved under insurances. Drug disease interactions we have to be careful with, and some of these we've already mentioned, that anticholinergics, benzodiazepines, high dose H2 blockers like famotidine, cimetidine, not as much ranitidine, can cause delirium. We already talked about falls and fractures, antipsychotics, benzodiazepine, opioids, TCAs. But guess what? You still may have to use these drugs, but what you try to do is use the lowest doses possible and prevent combination. Heart failure, we try to avoid calcium channel blockers, especially non-dihydropyridines like diltiazem and verapamil, because they can suppress the AV node and worsen ventricular cardiac output. Drugs that can cause fluid like the glitazones, NSAIDs, we try to avoid. Insomnia, drugs that can be stimulating, such as your amphetamines, avoiding caffeine when possible, or at least reduction of caffeine and no caffeine after 5 o'clock, and avoiding timing of certain agents, before 5 o'clock that can be stimulating. And when it comes to causing urinary retention problems, trying to avoid anticholinergics. When it comes to urinary incontinence, like urge incontinence, trying to avoid drugs that can actually weaken the internal sphincter by the bladder, and that's like alpha blockers. Parkinson's disease, we worry about antipsychotics, especially high dose and metoclopramide that can cause Parkinson-like symptoms. NSAIDs to reduce peptic ulcers. I talked about possibly adding PPI. Remember, it's PPIs. H2s don't help, just PPIs. Seizures. Some drugs can lower the seizure threshold, and it also can be dose related, like bupropion. The seizure threshold definitely increases when we approach 400 milligrams. And then several drugs can cause syncope, such as acetylcholinesterase inhibitors like donepezil, alpha blockers, antipsychotics, and TCAs. Does it mean that we never use these drugs? No, but if we have to use these drugs, we use them in caution and do monitoring. Also, too, looking at drugs that can affect interactions, trying to avoid them as possible, but if not, monitoring them. And you can read them self-evident. Obviously, drugs that interact with warfarin and theophylline, and lithium, think about narrow therapeutic drugs that have a very low window for toxicity. Adding two or more CNS drugs can increase the risk for falls. Adding alpha blockers to loop diuretics may increase the risk for urinary incontinence because the alpha blockers weakening the internal sphincter by the bladder. Anticholinergics, two anticholinergics are greater. That anticholinergic burden that I talked about that could cause confusion or cognition. But there's alternatives. Remember I said thiazide diuretics are good for use in isolated systolic hypertension. Angiotensin receptor blockers have less problems with orthostasis. Spironolactone is not a bad option in congestive heart failure, such as also in ethnic populations for congestive heart failure, hydralazine isoprodianitrate is a good combination. Another key area, and I'm not going to read every one of these that's on the slide, is that we really want to evaluate patients and whether or not they need renal dose adjustments. I know this is a challenge in community pharmacy because we don't always have access to labs, but if we see an 80-year-old patient, they're most likely have some type of renal impairment, and we should always look at what is the starting doses that they're on. Especially, you will see hits by, especially I've seen it with PACE and other insurances adopting these lists, and a lot of times it's going to just require the doctor to submit what is their renal function. Avoid renally cured drugs with chronic kidney disease. Duloxetine should be avoided if somebody has chronic kidney disease. How do you know that? Well, look at the drugs they're on. If they're on things like calcitriol, Foslo, calcium acetate, do you see them on getting Procrit? These are all indications, renal caps, that they are probably on chronic kidney disease. Using the the new oral anticoagulants, direct thrombin inhibitors, we want to avoid if they have chronic kidney disease. Most of them are contraindicated. Probenecid, which is rarely ever used, but a better alternative would be alpurinol. Alternative to some other renally clear drugs, glyburide. Better choice for elderly patients who need a sulfonylurea is glipizide or metformin. Meperidine, which should never really be used injectable or orally. Options are Tylenol, fentanyl, oxycodone, or tramadol. So, we've reviewed the list of the high-risk medications. Let's look at the impact of these high-risk medications and their criteria on value-based healthcare systems. So as I said, the Beers criteria, especially when it came out in 2002, has been adopted by lots of different organizations. It's been documented by the National Community for Quality Assurance, it has been adopted by CMS, and it has also been adopted by the Pharmacy Quality Alliance, and hence, that is where we get the listing in our high-risk star ratings. We're going to talk about that here very shortly, but I just want to share with you the STOP criteria. The STOP criteria is the other half of the START-STOP criteria, and like I said, I told you they were Irish researchers. O'Mahony, as we approach St. Paddy's Day, doesn't get any more Irish than that. And anyway, these researchers, the difference between the Beers criteria and the STOP criteria, they seem to be a little bit more inclusive, but one of the rules of the Beers criteria they had both in 2012 and 2015, they really only reflected on drugs that really was only impacted on geriatrics. Some of these others could be impacted in non-geriatric patients, and what I mean by that is we don't recommend aspirin greater than 160 anymore due to there's not a lot of benefit, especially in terms of prevention. We don't recommend in any patient with renal dysfunction using metformin below 30 mLs a minute. We caution patients who have diabetes on beta blockers because they could mask hypoglycemia. We need to be careful not using phosphodiesterase inhibitors such as sildenafil in patients with severe heart failure. We, obviously know that opioids can cause constipation. So a lot of these things are not necessarily geriatric, but the STOP criteria is out there, and every once in a while some organizations do a hybrid where they combine both agents. So whether it's the STOP criteria or the Beers criteria, implicit criterias sometimes can play. And one of the other things the STOP criteria did was they talked in that we shouldn't use drugs without a clinical indication, which that's pretty obvious. But one of the downsides we have sometimes in community pharmacy is that we don't always have access. What is their indications? Drug-drug interactions. We, obviously some classic ones. Don't use nitrates with phosphodiesterase inhibitors. Be careful that beta blockers, diltiazem and verapamil, they both suppress the heart, and so can slow down heart rate. How long should we treat somebody on an antithrombotic if it's their first DVT or pulmonary embolism? A lot of the literature says no longer than 6 to 12 months. So, what are the clinical tools and pearls for a community pharmacist to improve high-risk medications in the elderly. There's an app for that. The Beers Criteria does have an app out there, and the one thing nice about it is when you look up a drug, it'll tell you why to avoid it and also give you some recommendations of what to do. But classically, the best way to take care of a geriatric patient is to look at some take-home points. Don't let perfect be the enemy of good. All right, the Beers Criteria is a guide. It's not, guides are guides. It's not a mandate. Use it as a way to evaluate data. The other thing is, if you're going to stop a med, consider, are there withdrawal events? Do we need to taper the drug? It's not meant to supersede clinical judgment. If a patient's doing well on the drug and you don't see any symptoms, maybe we don't remove the drug. As I said, and I mentioned in prior talk, implicit criteria is another option where you ask the things such as, is there indication? Is the medication effective? Is the dosage correct? The directions correct? Are the directions practical? Clinically significant drug-drug interactions, drug-disease interactions. This is a great way to do it. It takes a lot more time. When you're getting into doing MTMs and you have access to the charts, this is a great tool to use. But if you don't have this tool, like I said, the explicit criteria is at least a start. Other steps to involve in doing good care for geriatric patients is doing a good med review, just like an MTM. Document problems, that they may say. Consult with the physicians. And also always evaluate adherence, prevent counseling and compliance aids where needed, and always do follow up with the patient. So, if I need to present a concern about a high-risk drug to a doctor, like I said, don't write, "Dear doctor, this is a Beers Criteria drug." Give the problem or assessment. Dizziness upon standing, when we were talking to the patient. We even took their blood pressure, and when they went from sitting to standing, their systolic pressure decreased by 20 millimeters of mercury. What's the possible cause? Well, it could be due to an adverse drug reaction, and the patient is currently on amitriptyline, which is known to cause orthostasis. Recommend consider discontinuing the amitriptyline, and maybe taper it. And you may even want to give the exact taper. And so, if you're making these physician recommendations, prioritize, think about the rationale, collect information, and offer some published literature. Like I said, don't open up with the bang and say, hey, this is a Beers Criteria drug. So let's look at some case examples and we'll finish up this talk. So here's a case example. You're the pharmacist working for Senior Community Pharmacy USA in January of 2015. The daughter and she's the medical power of attorney for an 80-year-old Caucasian male, Frank Costello, brings in 2 of his prescriptions for a refill: digoxin 0.25 once a day and glyburide 5 milligrams twice a day with breakfast and supper. Mr. VM has switched to the low assistance Medicare D plan Silver Scripts beginning in 2015. Upon attempting to process the 2 prescriptions to Medicare D plan, he received a rejection alert of the following for both prescriptions: medications not covered due to Part D law, high-risk medication. You relay this information to the daughter and ask her some questions. And so when she does, she says, well, here's why Dad takes these. He has type 2 diabetes, he has congestive heart failure. Oh yeah, and in addition, he has reflux, osteoporosis, and Alzheimer's dementia. And this is what he's on. So not only is he on glyburide, you look at his chart, he's also on metoprolol, he's also on omeprazole, alendronate, calcium citrate, and for that. But the daughter reports that her father has been doing well in the last year with his health condition. However, she does report he's had several daytime readings of his blood sugars between 60 and 70. When that occurs, his father reports dizziness and falling twice in the last 2 months. Daughter has the medical power of attorney. She also said last year they tried to take Dad off the dig, but he decompensated and was readmitted for a 5-day hospital stay. So here's his labs. Sugar's not bad. Hemoglobin A1C is 7.5 because he's elderly with dementia. The goal is just to keep his hemoglobin A1C below 8. His creatinine clearance isn't that great. His dig level is not, it's not within that range we recommend for like 0.6 to 1. And his, ejection fraction is low, so that does warrant dig. So you collected some information. He's hypoglycemic. His hemoglobin A1C is okay. So what do? We call the doctor, and instead of saying, "Dear doctor, these drugs aren't covered," or on that, or just ask the daughter if she wants to pay cash for them. Let's try the win-win approach. So we do this. We call the doctor and see if he's willing to switch him to glipizide, which has less risk, or maybe glimepiride. The other thing we recommend, because the daughter talked about how he got worse when he went off the DIDGE, let's just lower the dose. And by calling the doctor, giving these things, boom, it's switched. And you may also follow up with, say, hey, you know what we talked about, I'm going to provide that in a written form to you. Can I fax that to you? Here's an example of another patient. Look at this patient. This patient is an elderly gentleman. He's in his 80s, and he has a blood pressure of 135/60, heart rate that's very low. He has a creatinine clearance of 42, which anything below 60 is starting to approach stage 2 kidney disease. And he has cognitive impairment, and look how low his hemoglobin A1C is. So if we take a look at him, what are some Beers criteria drugs he's on? Take a moment to look. So you see he's on glyburide. He's also on DIDGE. He's on warfarin. He's on atololac, DoxySate, ferrous sulfate, metadine, metoprolol, gabapentin, essential fatty acids. He's also taking laxatives. So what do we do? Notice this patient, the glyburide, his sugars are low. Possibly switch him to glipizide. Maybe he doesn't need it at all. His DIDGE, look how low his heart rate is. Possibly warranted to the DIDGE, plus he's on a beta blocker. Either we evaluate to see if he needs the DIDGE, or we lower the dose. So using the Beers criteria, you can identify patients and what they do. The following slides are assessment questions, and these questions you can look at on the handout, and Greg will be reviewing those during your live session. Thank you very much, and if you have any questions about geriatrics or anything related to that, please feel free to contact me. And have a good day.